Today we'll be discussing endocrine questions that have appeared in the NEET SS and INI-SS. And we'll do a short video with around 10 questions. And so let's see the first question. So the first question is middle-aged female presented with headache and visual symptoms. So we can see here that there is a headache and visual symptoms along with amenorrhea. Prolactin was 100 and other anterior hormone levels were normal. And on perimetry she was found to have bitemporal hemianopia, and MRI cellar revealed a 2.2 centimeter sized adenoma, which is obviously impinging on the optic chiasma. And so what would be the next step? So what are the things that the options are telling us? One is bromocriptine, another is cabergoline, third is transphenoidal surgery, and fourth is radiotherapy. So we have a middle-aged female with all these features. The primary features that we need to be very worried about is headache, as well as visual field defect, and there is hyperprolactinemia. So here what we need to understand is that what is the etiology of hyperprolactinemia in this case. So what we need to do is, if there is prolactin is increased, say for example, so we need to find out what is the cause. So they can be physiological. Physiological causes are going to be pregnancy, lactation, REM sleep, extreme stress, so these, and chest wall stimulation. These are going to be your physiological causes. Then there are going to be systemic disorders. What they will be? They can be CKD, can be cirrhosis, they can be hypothyroidism. So in CKD there will be a reduced clearance of prolactin. Cirrhosis also, there will be a lot of prolactin production may be there. Hypothyroidism, there can be TRH is going to increase, and that will cause activation of the lactotroph cells. That is why this hypothyroidism should always be ruled out in a patient who is coming with hyperprolactinemia. Then there can be pseudocyesis, and then there can be epilepsy. Epilepsy as in epileptic fits. Now there can be another thing, that there can be adenoma because of the through the adenoma itself. So functional adenoma. So that can be prolactinoma and acromegaly. And next, the most very important part comes to be because of stop effect or interruption. So what can be the causes? In case of stalk effect, any adenoma, this is, for example, this is the pituitary. We can see this is the pituitary, say for example, and this is the stalk. So any adenoma is pressing the stalk. So the dopamine is not going to go through, and this is the prolactin inhibiting factor. So if this is not going to go through, prolactin is going to go up. And the important part is that prolactinomas In prolactinomas, the size is directly proportional to the secretion. That is, larger the adenoma, more is the hormonal secretion, which is not the case with Cushing's. That is ACTH secreting adenoma. Here even small adenomas can cause massive secretion of hormones. The other cause is going to be drugs. Drugs can be multifold. They can be antipsychotic drugs, maybe atypical, typical. The one that will cause the most increase in prolactin is risperidone and haloperidol. And there are multitude of drugs, including your metoclopramide. There can be opiates, there can be dopamine, that can be heparin. So, but coming back to the question, what we can see here is that there is no mention of any drug here, no drugs, no mention of any microadenoma. Rather, it is a macroadenoma. And the Williams states that if the secretion is more than 300 nanogram per ml, then it is prolactinoma or prolactin secreting adenoma until proven otherwise. And more than 500 is without a doubt prolactinoma. So that is not the case here. And the other thing is, the other anterior pituitary hormones are normal. So if there is not a clear-cut adenoma, so the medical management goes off, because the medical management is the treatment of choice for microadenomas. Then transsphenoidal surgery is there and radiotherapy. So in case of this transsphenoidal surgery, when do we go for transsphenoidal surgery in prolactinomas? So number one, if there is any visual field defect or headache, that is mass effects, and they are not responding to classical management, that is the first case. Then there is resistance to treatment, resistance to dopaminergic agonist. When do you say that it is resistant? When there is no normalization of prolactin or less than 50% reduction in volume over 1 year. Thirdly, there is recurrence, which is around 20% in case of microadenoma and around 50% in case of macroadenoma. And this, I assume that you know that microadenoma is less than 1 centimeter, macro is more than 1 centimeter, and giant prolactinoma is more than 4 centimeter or having more than 2 centimeter suprasellar extension. So when it comes to this question, transsphenoidal surgery seems to be the correct answer, because bromocriptine cabergoline is not going to be the treatment of choice, since it is not a prolactin secreting adenoma. The other thing is radiotherapy is not used in prolactinoma or sparingly used only when there is recurrence and patient is not ready for surgery. Now you may ask that why the anterior pituitary hormones, other anterior pituitary hormones are normal. So the cause for that is that the lactotrophs are most sensitive cells to their trophic hormones, that is dopamine. So once if this is not there, then suddenly the prolactin will go up, while the other anterior pituitary hormones will take a lot of time and lot of destruction or lot of mass effect for them to undergo any changes in the serum levels. Hence the answer is transsphenoidal surgery. So the take home message here is, if there is any visual field effect or any mass effect, there is, you can see that if the question mentions that there is some papilledema, there is some bitemporal hemianopia, more or less the answer is always going to be transsphenoidal surgery. So with this we will move to the next question. Coming on to the next question. Patient with Cushingoid features is having resistant hypertension and hypokalemia. The HDDST is non-suppressible and the CT chest shows a mass in the lung. Most common etiology of this condition would be. So what we are looking at here, if the HDDST is non-suppressible and the patient is having hypertension and hypokalemia. So they are giving us two clues. So the first clue is the clinical clue. So hypertension and potassium levels, that is hypokalemia, is seen only in 15% of the cases in case of Cushing's disease or ACTH dependent causes, while this is seen in almost 90 to 95% cases of ectopic ACTH producing Cushing's syndrome. So first clue is this. The second clue is HDDST should be suppressible if it is a pituitary dependent cause. Why? Because if we are giving in HDDST, what we are doing is we are giving 2 mg dexamethasone 6 hourly for 48 hours, and then we look for the cortisol levels and whether they are suppressed to less than 50% of the levels, less than 50% of the basal value. So when this will work is when the ACTH excess from the pituitary is causing the adrenal release of the cortisol. This will happen when this axis is intact. But as we see in this question that they have a chest lesion, a lung pathology. So it is a ectopic ACTH producing Cushing's syndrome. And what are the other clues they could have given? If the ACTH is more than 20 or 22 picogram per ml, then it is a pituitary dependent cause or the ACTH dependent cause. But if it is more than 90 picogram per ml, then it is a ectopic cause. If the HDDST is non-suppressible, it is an ectopic cause. If there is no response of ACTH to CRH, it is a ectopic cause if there is no gradient in IPSS, inferior petrosal sinus sampling, it is an ectopic cause. And now what are the etiology that will lead to ectopic ACTH producing Cushing's syndrome? The first one, the most common, is small cell carcinoma of the lung. The second is non-small cell carcinoma of the lung. Then there is pancreatic net. Then there is thymic net. Net is new tumor. And then there is lung net. Then there can be pheochromocytoma. There can be medullary thyroid carcinoma, and very rarely there can be CA breast, prostate, and CA colon or CA gallbladder. So coming back to the question, what we see here, most common etiology in this condition. What is this condition? It is ectopic ACTH producing tumor, producing Cushing syndrome, So small cell lung carcinoma is the most common cause. Okay, so we'll move to the next question. Coming on to the next question, 65-year-old female with history of multiple vertebral fractures. This is a very important point, vertebral fractures, and is a known case of CKD with elevated creatinine, T-score of minus 2.4, and what is the most appropriate drug for the patient? So we are talking about when do we treat for osteoporosis. Osteoporosis treatment should be initiated, number one, when there are multiple fractures or fragility fractures. Fractures or even a single fracture. Where what is of this fragility fracture? When there is a fall from less than the standing height or from the standing height only, and it's a trivial fall and it causes a fracture. Fracture of what? The hip fracture, or there is vertebral fracture. So that is the time we treat. Then there is the BMD criteria. So what is the BMD criteria? The bone mineral density criteria is going to be if the BMD T-score is less than minus 2.5. That is, it is either minus 2.6, minus 2.8, so on and so forth. So, and this T-score is to be measured either at the hip or at the neck of femur or at the lumbar spine. So T-score less than minus 2.5 is osteoporosis right away. But if the and this cutoff is for osteoporosis, while if there is osteopenia, that is T-score is minus 1 to minus 2.5, what do we do at that time? So at that time we calculate the FRAX, which is the fracture risk assessment score or tool, and here we look at various things like the age, what is the gender, whether the patient has a family history of a osteoporotic fracture or fragility fracture or a vertebral fracture, either in themselves a past history or if there is a history in a first degree family member that we look at. We look at chronic glucocorticoid use. We also look at whether there is a smoking history, whether there is a history of more than 3 units of alcohol, whether there is rheumatoid arthritis history, all these things, whether the patient is menopausal or not, and we look at the neck of femur BMD. So these things, and if the risk of major osteoporotic fracture is more than 20%, or the risk of hip fracture is more than 3%. So that is the time we treat the patient. And another thing of importance is, if there is a chance of vertebral fracture, if there is a history of vertebral fracture or fragility fracture at that time, or a hip fracture, so we treat the patient directly irrespective of T-score. So coming back to the question, multiple vertebral fracture, this is the first clue. The second clue is the T-score is minus 2.4. So they want to confuse us. This is the osteopenic range. But we treat the patient if there is a vertebral fracture irrespective of the T-score. So that is there. So we have to treat. Now what we have to treat it with? So here comes the third clue. The patient is CKD. In CKD, what we need to understand is that zoledronic acid, it is an anti-resorptive agent, and it cannot be given to any patient who is less than 30 ml per minute EGFR. So in CKD, this goes out of the window. Nasal calcitonin is given for pain relief, or it is given for hypercalcemia of malignancy. It has no role, or very limited role rather, in osteoporosis. Coming on to teriparatide and denosumab. So these are the two wonder drugs. So in case of teriparatide, this is the wonder drug. It is recombinant PTH 1 to 34, and this has to be given subcutaneously 20 microgram per day for a maximum of 2 years. But it cannot be given in CKD because of secondary hyperparathyroidism. Already there is increased PTH, so we cannot give this recombinant PTH along with that. Although this is the treatment this is the drug that we start with in a postmenopausal osteoporosis, the garden variety of osteoporosis, where we need sequential treatment according to the latest study in AACE. So what they are suggesting is that we start with teriparatide, which is an osteoanabolic agent. It is an anabolic agent. It is an anabolic agent, and then we go for denosumab. So this will give a synergistic effect and improvement in T-score. Now we come to, as per the options, to denosumab. This is 60 milligram subcutaneously every 6 months, and this is a rank ligand inhibitor and can be given in CKD patients. So very good response. What we need to be wary of while using denosumab is we should not stop it abruptly, because suddenly the bone turnover markers, especially the resorption markers, suddenly go up, and there is an increased risk of fracture on sudden stoppage. So that is where we need to be very, very careful. And whenever we are about to stop this, we can always start with an anti-resorptive treatment, such as your zolindronate or alendronate or pamidronate. Not in this case, but in other cases where CKD is not there. So here the drug of choice is denosumab, which can be given for considerable amount of time of say about 3 years. Alright. Coming on to the next question. So what is the growth rate? Maximum growth rate is seen in, so pre-pubertal years, first 2 years of life, fetal life, mid-childhood. So what is the newborn length? It is 50 centimeter. What is the height velocity? So that is what they are actually asking us. They are asking us the growth rate. So growth rate is actually height velocity only they are asking. So height velocity in the first year is 25 centimeters. Second year it is 12 centimeters. Then in the third year it is 8 centimeters. And then it is 5 centimeter from the fourth year. And this continues till the just pre-pubertal years. Here the pubertal growth spurt is 28 centimeter in male and 25 centimeter in female, and it accounts for 9.5 centimeter per year and 8.3 centimeter per year respectively. So we have the answer. Pre-pubertal years for male it is 9.5 and 8.3 centimeter. First 2 years of life it is 25 centimeter followed by 12 centimeter. Fetal life it is 50 centimeter length total. So it is not the height velocity. Mid childhood it is 5 centimeter per year. So the answer here is clearly first 2 years of life. Coming on to the next question. Testis determining factor is. So what they are actually asking us is what is sex determination versus sex differentiation. So what is sex determination? It is when the bipotential gonad, the gonad is bipotential till 6 weeks, 6 to 8 weeks. Some places it is written 8, but it is around 6 weeks. And from there, whether it develops into testis or it develops into an ovary. And how it is determined? It is determined by the presence or absence of Y chromosome. So the question is on another level. What part of the Y chromosome actually decides as to how the bipotential gonad will develop into testis? So Y chromosome is actually divided into heterochromatic and euchromatic regions. And this euchromatic region actually contains the SRY gene in the pseudo-autosomal region. And this actually is known as the testis determining factor. So we can see it here. WT1, GATA4, SF1 and CBX2, they all lead to SRY. This is the testis determining factor. Alright. After this SF1, what it does is SRY actually activates the SOX9, and SF1 will also direct towards the SOX9, which inhibits the Wnt4 pathway via FGF9. Wnt4 is actually involved in ovarian development. This SOX9 will now act in a paracrine manner on Sertoli cells, which act again in a paracrine manner via the hedgehog protein. And this Sertoli cell and Leydig cells will further form the following compounds. The Sertoli cells, as we know, gives rise to AMH at around 9 weeks. And this is the anti-Mullerian hormone. Anti-Mullerian hormone will actually cause regression of the Mullerian ducts. What are the Mullerian organs, the ducts that develop? Them are uterus, the upper 1/3 of the vagina, upper 2/3 of the vagina, and the fallopian tubes. While the Leydig cells will give rise to INSL3, and it is actually part of the relaxin family, and this causes the descent, testicular descent. And Leydig cells also give rise to testosterone, and testosterone will give stabilization towards the Wolffian ducts, and that will cause the development of the male internal organs, namely the epididymis, the seminiferous tubules, seminiferous vesicles, and the vas deferens. While after getting converted to 5-dihydrotestosterone via 5-alpha reductase type 2 will give rise to the external genitalia, that is the scrotum and the penis. So this is the sex determination. While sex differentiation, on the other hand, is the development of the internal genitalia and external genitalia as guided by the gonad. So first the sex determination occurs, and then the sex differentiation occurs as per the development of the gonad, from the bipotential gonad to either the ovary or the testis. While testis is determined by the SRY gene present on the pseudo-autosomal region of the Y chromosome. That is the primary gene which is responsible for initiating testicular development. Thank you. Next question. Originator of the GnRH pulse generator is? The options are kisspeptin neurons, GnRH neurons, anteromedial part of the periventricular nucleus, or arcuate nucleus. So this is a very tricky question, because originator of the GnRH pulse generator. So although the location of the GnRH pulse generator is the arcuate nucleus, it actually does not generate the pulse. The origination of the pulse of the GnRH pulse is actually by the Candy neurons that are located in the arcuate nucleus, and Candy is an acronym for K, N and D. So K stands for kisspeptin, and this directly stimulates the GnRH neurons to go for the GnRH generation, as it stimulates them in a pulsatile manner, and this will go on to increase the FSH-LH and further go on to initiate the puberty. While neurokinin initiates the pulse and dynorphin terminates it. So according to my assessment, this question, if they had asked the location, then the answer would have been arcuate nucleus. But since they are asking the originator of the pulse generator, that means that according to me, since neurokinin is not in the options, neurokinin B actually initiates the pulse, while the GnRH is directly stimulated by the kisspeptin neurons. Or a better option would have been Candy neurons. So in recall there might have been some issue, but even kiss peptin neuron seems to be the more correct answer as compared to the arcuate nucleus, which merely is the location, but it does not cause the initiation. The initiation is caused by the candy neurons, specifically the neurokinin B, followed by GnRH cell stimulation by the kiss peptin, and then the pulse termination by dynorphin. On to the next question. Young patient with palpitation, restlessness and tachycardia with a small painless goiter. The next diagnostic step would be, so what they are suggesting is there is thyrotoxic symptom. And what can be the cause? So thyrotoxic symptoms, the causes can be as follows. One is Graves' disease. Second is subacute thyroiditis, that is the toxic phase of subacute thyroiditis. And the third can be a toxic MNG, multinodular goiter. So what will help us differentiate between these etiologies? That is essentially what they want to ask. So we will go towards the MCQs one by one, towards the options one by one. So we come to anti-TPO antibody. So what is the purpose of this anti-TPO antibody? It tells us about the etiology. What kind of etiology? Whether it is autoimmune in nature or not. It does not tell us whether this toxic symptom is because of a Graves, or whether it is because of a toxic MNG, or whether it is because of subacute thyroiditis. USG Doppler, radioactive uptake scan and thyroglobulin levels. So first we will come to thyroglobulin levels. When they are measured? They are measured when we suspect that there is thyrotoxicosis factitia, that a patient is actually taking thyroid hormone from outside and that is causing the toxic symptoms. Or we suspect that there is some cancer and we need to test whether there is some residual thyroid tissue left post surgery or post ablation, whatever be the case. So in case of thyroglobulin levels, what we need to understand is कि if there is a tissue left, then thyroglobulin levels will be high, and we also have to check for anti-thyroglobulin antibody. So this is in case of post surgery, we need to check for any residual tissue. That is when we go for thyroglobulin levels. And the other thing is, if the patient is taking, if they are taking thyroxine from outside, then this thyroglobulin is going to be absent. Why? Because it is not endogenously produced. There is no coupling. There is nothing in the thyroid follicular cells. So this thyroglobulin is very, very specific to endogenously produced thyroxine. So that is the purpose of doing thyroglobulin levels. Now we come to USG Doppler and radioactive iodine uptake scan. So in USG Doppler, in resource limited settings, what we do is we look at the peak systolic velocity of the inferior thyroid artery. Peak systolic velocity of the inferior thyroid artery, and if it is more than 30 centimeter per second, it is suggestive, and more than 50 centimeter per second, it is almost definitive for Graves' disease, because the vascularity is increased in case of Graves' disease, which is not the case in case of subacute thyroiditis or MNG. Here the gland itself is getting destroyed and the stored hormones are actually getting released in the circulation. So initially there will be a toxic phase followed by a euthyroid or a hypothyroid phase of around 6 to 8 weeks, 6 to 8 weeks. Now we come to radioactive iodine uptake. This, on the other hand, is the investigation of choice and the gold standard to understand the etiology of thyrotoxicosis. So what is going to happen? What is going to happen in Graves' disease? In Graves' disease, you are going to have a very, very increased uptake in both the lobes of thyroid gland. In subacute thyroiditis, there is going to be a patchy uptake. Some patchy uptake here and there is going to be there. While in case of MNG or a toxic nodule producing the hormone, it is going to be somewhat like this, that this is the toxic nodule and it is suppressing the whole of the other gland. So this is the gold standard radioactive iodine uptake is the gold standard. The last question. So what we need to see here is it's a 40-year-old obese male with hair loss and was detected to have low serum testosterone levels with normal LH and FSH levels. And what can be the likely explanation? So the options are obesity induced secondary hypogonadism, primary hypogonadism, low SHBG level and orchitis. So to label a person as hypogonadism, there are some prerequisites. Number one, they should have symptoms. Symptoms should be there of low testosterone levels. Then testosterone single measurement is of no value. Testosterone needs to be measured 2 times. Should be measured coupled with FSH-LH. Patient should not have any acute or chronic illness, should not be hospitalized because that can cause falsely lowered testosterone. Or any condition that might alter the sex hormone binding globulin. At that time, we cannot label the patient as hypogonadism. Now, so this option seems to be out. Primary hypogonadism, on the other hand, the testo should be low and the FSH or LH or both should be high. That is not the case. Patient is not having any overt symptoms. Orchitis seems to be not there. So in this case, we can directly by exclusion go towards this correct answer. We may not need to know the things in detail, but here we have gotten lucky. So we need to know what are the SHBG altering conditions. And mainly what causes decrease in these conditions. So the first one is obesity. Then there is hypothyroidism. Androgens. Hyperinsulinism or insulin resistance. Increased cortisol levels, which may be endogenous or exogenous, and there can be growth hormone increase in cases such as acromegaly. So what is going to happen? if the SHBG is going to come low, the total testo, that is free testosterone plus SHBG, is going to reduce, while the FSH-LH will remain normal, as the free testosterone is normal, and free testosterone is the one that maintains the negative and the positive feedback. So, in these cases where SHBG alteration is there, we need to go for either the free testosterone levels or the free testosterone index. So, free testo is to be done in these cases. And this is the reason why the FSH-LH is normal and the patient is asymptomatic, because the free testo remains normal. So hence the answer to this question is low SHBG levels, as obesity is one of the very common conditions that reduces the SHBG levels, and that causes reduction in the total testosterone level, while the free testosterone level remains normal, keeping the FSH-LH normal and patient asymptomatic. Thank you.